I will say that I've seen some people that have really been crashing, and I didn't think there was any way to salvage them other than intubation. But to be quite honest, the probably 80% of the people that I intubated were during a week-long stretch about a month ago when I was being told that we need to intubate all these people early. Since then, I've had very good success, a lot of success with high velocity, and we're still using some positive pressure, not intubating these.
This is Velocity from Vapotherm. In this series, we join conversations with clinicians, educators, and researchers to explore topics in respiratory care. Today's episode is a continuation of last episode, where we joined 5 ED physicians as they reflect on their COVID-19 experiences so far. In this episode, they discussed the widely shared research of Dr. Gattinoni introducing 2 patient phenotypes, maybe you've seen that around, and the use of Vapotherm high-velocity therapy, or HV&I, with their COVID-19 patients. Today, you're going to hear from Dr. Kirk Hinckley, Dr. Adam Hennessy, Dr. Michael Bubowitz, Dr. Ross Simcoe, and Dr. Mark Gebhardt, who still has the best Zoom background I've seen in one of these roundtables yet. Dr. Hinckley is a member of the Vapotherm team as Director of ED Education. The rest of today's participants are paid consultants. While we're speaking with 5 doctors today, it's worth noting that Vapotherm does not practice medicine, provide medical services, or provide medical advice. Any clinical recommendations in these conversations are solely those of the speaker. For any devices mentioned, please refer to the instructions of use before use. Now, let's rejoin Dr. Hinckley in that conversation.
In a recent article in Intensive Care Medicine, the Italian Dr. Gattinoni, who's a prolific publisher on ARDS, posted that COVID patients are presenting with 2 distinct phenotypes, what he calls the L subtype, or the silent hypoxemics, who they found to have good lung compliance and respond well to oxygen therapy, and then the H subtype, which are more ARDS looking. Is that your experience? Have you seen that in Houston?
So my personal experience, because we have not quite hit the critical mass of patients showing up, I haven't had a concentration of a lot of critically ill patients. So each shift I get 1 or 2, but not each of them critically ill. So I personally haven't experienced that. I know that those discussions are happening in our critical care circles, and we do have weekly meetings with the critical care representation across the system. I will say that relative to the total number of cases we have in our system, we have very few folks on ECMO, only a handful, and that's sort of that's representative of the entire city, of the 6 million people in Greater Houston area. So, I really can't speak to that too much with experience.
Sure. But Ross, you mentioned that there's some patients that you've intubated as they hit the door, and others that you've managed successfully with HV&I. So, what are your experiences about these phenotypes?
These phenotypes are completely accurate. And you can, it's probably best seen maybe the transition between the two of sometimes when you have bounce back patients, because of course we can't admit every single person that we think is COVID positive, but maybe it's the patient that you got an x-ray on, their stats were fine, and then 3 or 4 days later they bounce back to your ER and have a significantly different x-ray, significantly different presentation. I will say that I've seen some people that have really been crashing, and I didn't think there was any way to salvage them other than intubation. But to be quite honest, the probably 80% of the people that I intubated were during a week-long stretch about a month ago when I was being told that we need to intubate all these people early. Since then, I've had very good success, a lot of success with high velocity, and we're still using some positive pressure, not intubating these folks. I admitted 3 folks yesterday who were all on either high velocity or positive pressure, who came in with respiratory rates in the mid to high 40s, and hypoxia as low as 52% in one patient. And was able to get them turned around pretty quickly in the hour or two before I admitted them to the hospital.
Okay, Adam, more experience from Philadelphia?
Yeah, I think the different phenotypes puts a lot more, or sheds a lot more light on this disease process. It's one of the benefits of being somewhat late and having seen what Northern Italy and Asia have gone through, and even Washington State. Early on, I was talking with our pulmonologist, trying to figure out if there was a subset of patients that were just going to go to ARDS no matter what, or if there was something to intervene on. And they were of the thinking that there's probably some patients just going to progress to it either way. And these phenotypes do demonstrate that. I guess there's some that they suspect probably present just as the H phenotype, opposed to others that progress from the L with the good lung compliance, and then progressing all the way to the more ARDS picture of the H phenotype. But if that's the case, and there's something between point A and point B that hopefully we can intervene on, and presumably it's the hypoxic failure and getting as much alveoli recruitment as possible as they may start to deteriorate. And that's one of the great things about these modalities of high flow and high velocity, because you're allowing them to manually prone. We had a patient just the other day who was just shifting side to side every hour or so. He was laying on his abdomen a little bit, and he tolerated it fine. One of our former employees came in as one of those, probably the L phenotypes, technically, as they would call it, like a happy hypoxic. I don't know how happy he really was, but he was talking with us. He wasn't in overt respiratory distress. And interestingly enough, he was a bad asthmatic, and he wasn't wheezing, which I don't know about you guys, but I've been seeing a lot of patients that you think should be presenting as a COPD exacerbation or an asthma exacerbation. Their lungs are perfect on auscultation. So there's definitely a difference between these two phenotypes, and we're fortunate enough to have the knowledge of all the people that went before us with this disease, even though it's only been 3 months. And I think that's going to help us a lot moving forward. And I think that's important as clinicians when you're approaching these patients, of determining nobody's going to be 100% one or 100% the other necessarily, but determining which they are. And that's really what guiding therapy. If someone's a bad of the H phenotype where you think they're going to be really sick, they're probably going to be somebody who's going to ultimately trend toward intubation. They might be somebody who early intubation is better, but the vast majority, like Ross said, and I think the literature says too, about 80% should in theory at least start off with more supportive measures. And that's what we've been seeing too.
And Mark, anything to add on this point?
You know, I have similar experiences. I've seen actually more of the happy hypoxic phenotype of the bunch, but I will give you 2 cases that I know my colleagues and my obstetric colleagues related. We had some really profound dyspnea in 2 pregnant women who presented. The first was a G4P3 at 32 weeks, and the second was a G1P0 at 34 weeks. Both presented hypoxic, profound respiratory distress, cyanosis, strikingly abnormal chest x-rays, went to the intensive care unit. Ultimately, OB sectioned both of these individuals, and they were sent to a tertiary facility. Both are on ECMO now and doing poorly. Yeah. So, very different picture, quite an accelerated illness in those pregnant patients. And so they were clearly not the happy hypoxic that many of the other people I see are.
And we're going to go back to Adam, because Adam, you touched on proning. And so how are you using HVNI in the clinical management of COVID patients? How do you select for those patients? And what areas of treatment are they going to? Are they staying in your ER? Are they going to the ICU? Can they go to the step down or floor units? Are they doing, how are they doing titrations or weaning from vents with HVNI? Are they using proning techniques? And any particular markers or triggers for intubation?
First off, from a level of care standpoint, our hospital is somewhat unique because we've been using it for so long. Pretty much the only limitation in our hospital is a telemetry monitor and necessary hookups. So there's a couple of telemetry beds in the hospital that I've been told just physically don't have the necessary hookups on the wall because some of the hospital's a lot older. But depending on the patient's clinical condition, we can place someone on HVNI from telemetry, our step down PCU unit, all the way to the intensive care unit. And that was even before COVID. That's how we manage these. In our department, we set up more than half of our rooms now are either negative pressure or isolation with a HEPA filter. So we do try to, while we still have the luxury of space, anybody who's on HVNI, they're wearing a mask and we have them in a room that either has negative pressure or HEPA filter, and we're still wearing full PPE if they are on HVNI. With regards to proning, I can't really speak to the ICU. I know they are proning ventilated patients up there. They do it for not the entire day, but for sections of time to help with recruitment. We've been just placing them on the HVNI, and if they're comfortable enough to sit almost at like a 90-degree angle, that probably works just well, if not better. The ones that are a little bit more uncomfortable, or if they can tolerate it, we have them rotating, if maybe rolling for staying on one side for an hour, another side for an hour or so. They can lay on their abdomens and just kind of continuing that movement, and because we can't really have them walking up and down the halls either. And they seem to, I've only had maybe 2 or 3 that I've used it for so far with proning, and they seem to be doing pretty well with it. And from the inpatient side, there's really no restrictions on them because they're all getting isolation beds as well.
Yeah, no, kind of similar to Adam. Fortunately, we don't have to board these patients in the current state in the ED yet with the volumes that we have and the critical care capacity that we have. So for those patients that, that can cooperate, that are, comfortable enough to manage themselves, then absolutely we've got enough of that capacity to effectively manage them like Adam and his shops.
Yeah, I'm gonna echo what Michael and Adam said, that we're kind of doing those same things. I would say that, as with any other respiratory failure condition, that high velocity nasal insufflation is generally my go-to treatment modality, usually starting somewhere around 35 to 40 liters per minute and titrating the FiO2 as needed. But it seems to be this in combination with proning patients that most of them are able to do, and they're pretty comfortable with doing it. I've been seeing pretty good results. I don't have any hard, fast rules for who progresses to intubation. It's really more of, for me, just a clinical gestalt. So I don't know if we've come up with any like definite decision trees or pathways, especially the shop that Adam and I work at. It's just a very, very heavy clinical medicine that you just go see the patient and do what you think you need to do.
Similar experiences to what the rest say. These happy hypoxics done marvelously on high velocity nasal insufflation. The case I presented to you gentlemen just the other day. Near immediate response to that, suddenly, the O2 sat surging and an overall better condition. Our intensivists across our system, I was actually just looking, we have a protocol that they've put in place regarding proning. So I think from the critical care side, they're actively doing it, and they actually have a guideline and a protocol in place to employ that treatment modality.
A couple of you have mentioned safety concerns raised by respiratory therapy and others about HVNI and aerosolization and potential for viral transmission to healthcare workers. How have you been addressing in the ER these concerns, and has that affected patients that you wanted to put on HVNI? What kind of precautions are you following to minimize the transmission risk? And I think we've had a couple of answers on this, but and is your ED familiar with the CHEST paper published by Leonard and DeBellis and Dungan?
So each day we get more facile with operationalizing this. I think each day we learn from the previous day is real exposure risk, how these patients present, how they look, what it's going to take care of them. We get some wins under the belt as well when you start using various technologies in different ways, and HVNI with a mask, and you realize that these patients shouldn't be doing very well when you follow up on them. We have sort of an obsessive concern with staff safety here, which is, I think, very, very appropriate considering the exposure risk overall in this profession and currently right now. So we've, as I mentioned, we're well supplied with PPE. We have in each of our ADs designated COVID sections that are separate from the general population. Those individuals have extra layers of protection and a lot of education around donning and doffing your PPE appropriately so you don't contaminate yourself. So we go through these rigorous exercises to make sure that we keep staff safe. So the chance that there is any aerosolization, we minimize that risk of that aerosolization being transmitted to the clinician, the nurse at the bedside, respiratory therapist, and it's incrementally improved week after week in order to get there. But when you put these extra layers, these extra measures in place, I think it goes a long way with the staff in giving them that extra security. Even if it is a belt and suspenders situation, some of these are very low-tech, non-expensive solutions that help mitigate the risk in general.
Ross, you mentioned that you've had to use the chest paper published by Leonard and others to help educate. Can you comment on that?
I've referenced the chest paper, and there's some other resources online as well that just really show the safety that I think all of us understand when high velocity is used with a surgical mask compared to other modalities. And I think this is one of those things that, in general, if people are more comfortable using BiPAP or CPAP or other modalities, and you're asking them to use something newer to them, they don't think it's going to work and they're scared of it. And so it takes a little convincing. It takes a little bit of digging, taking a deep dive into the research and actually showing them, no, there's been some papers on this. There's been some studies. If you use high velocity, the aerosolization of particles is going to be between 10 and 20 centimeters. If you're using BiPAP, it's going to be almost a meter. And this is the best scientific data we have right now. So I definitely had to pull out some of this chest paper in specific, and some of the nice graphics that are available at different sites and different publications have been very helpful as well.
Mark, how have you used the paper to help educate your staff on their safety?
I pretty much keep myself constantly armed with paper. So in my lab coat or, at my desk, I keep this. I found this to be so helpful in actually giving them a quick visual representation. And I don't know, gentlemen, if you feel the same way. I think that almost the name VAPO, when we started discussing, it caused the RTs to just get this instantaneous fear, as if we were generating this massive cloud that was going to expose them. So using that paper and having that saved on my iPad has been my immediate go-to. And it's been pretty well understood. Most people see it right in front of their face, and then they'll feel a little bit more comfortable. We also have documents that critical care medicine puts out within our hospital on a weekly updated basis. And so, Vapotherm is mentioned repeatedly there. And I can tell you, there's been this evolution over the past few weeks from don't touch it ever to now it's the acceptable go-to method to use.
Adam, any safety concerns?
Some of what people have raised and that we've kind of been drilling home. I think that there's two approaches to it. One is the safety for patient and the safety for the provider that people are starting to grasp now, and that it's agreed upon that intubation is going to be the highest risk for the provider if we get to that point, opposed to all the other modalities. Despite everything else you do using video laryngoscopy, some type of protective barrier, there's still the highest risk for aerosolization from there. So anything we can do to minimize intubation of these patients who potentially could be avoided, that's one thing. And then also for the patient. So BiPAP and intubation are higher risk for us as providers from an aerosolization standpoint. And I think those graphics you've shown are excellent for that. But then also for the patient, the intubation probably isn't beneficial for a lot of these patients. It might be leading to a faster progression to the ARDS type picture. And BiPAP is not at least from most of the newer research showing, isn't as recommended as high flow or high velocity. It's not even from a provider safety standpoint, but from a patient safety. So I think once you approach it with that's both safer for the patient and safer for the providers, it helps gaining more ground. But it's taken a little while, even though this has been such a fast moving process over the last few months. It definitely has taken a little bit to get the support.
Yeah.
Thank you for joining us on this episode of Velocity from Vapotherm. We hope you enjoyed this, and wherever you listen to it, thanks for listening, and be sure to subscribe, whether that's on Stitcher, iTunes, Google Podcasts, YouTube, wherever. We've made this pretty easy to access, but you'll probably miss it if you forget to subscribe. Are you looking for more information about Vapotherm, any of the topics we've talked about today, or our therapy? Well, visit us at vapotherm.com. At vapotherm.com, you'll find information about all of these things, either in our blog post throughout the pages or on Vapotherm Academy, which it's worth noting also has continuing education opportunities for RTs and nurses, as well as a plethora of amazing topics covered there. So thank you very much for joining us, and thank you for everything you do.